Hi, everybody, and welcome to the latest Hear from the Experts webinar. The series is helping people better understand multiple sclerosis and provide tools to navigate their MS journey with more knowledge and confidence. Our intention is to help you learn more about the disease, the treatments, research, wellness strategies, and a whole lot more. I'm Shauna McKinnon. For over 35 years, I was a radio announcer, capping things off as an afternoon announcer and music director at Cruise FM in Fort McMurray, Alberta, but I retired in April of this year and moved back home to Nova Scotia. I was diagnosed with MS almost 25 years ago, and since my diagnosis, I have volunteered for the MS Society as a speaker and moderator, an MC at many walks and bike events, and as a participant. This year marked at least my 14th MS bike ride. I've kind of lost track of them. I'm also an MS ambassador and previous council member in Fort McMurray. I love nature, especially bugs, and you can most often find me playing outside, and I'm your moderator for today's broadcast. Before we get started with our presentation, though, let's briefly go over a couple of housekeeping items. Your microphones have been muted and will remain muted for the entirety of the presentation. The webinar is being recorded and it will be available soon on our website in English. We are also adding French subtitles to the recording, but that version won't be available for several weeks. The recordings will be available on our website under Nationwide Webinars from the archived page and on our YouTube channel. If you have a question for today's presenter, please type it into the chat box on the right of your screen, and we will try to get to as many questions as possible following the formal presentation, although we have received some pre-submitted questions to help get us started. The session is also being broadcast on Facebook Live, and we welcome that audience to the session, and also you can type any questions into your chat box there. Please note that questions pertaining to specific personal situations likely cannot be answered in this type of venue. We do recommend contacting your personal MS healthcare team or perhaps contacting the MS Knowledge Network for those questions. Speaking of the MS Knowledge Network, we do have staff, including an MS Navigator, monitoring the chats, and they will share additional information when able. Also, please note that the MS Society of Canada does not approve, endorse, or recommend any specific product, therapy, or service, but it does provide information to assist individuals in making their own health and wellness decisions. Today's presenter is Dr. Jody Burton, who obtained her Bachelor of Science degree in 1996 and her medical degree in 2000 at the University of Toronto. She then completed a neurology residency, spent 2 years in a multiple sclerosis fellowship with Dr. Paul O'Connor, and obtained her Master of Science degree in clinical epidemiology at the University of Toronto. She was on staff at the Toronto MS Clinic from 2007 to 2009 until she joined the Department of Clinical Neurosciences and the MS program, as well as the Department of Community Health Sciences at the University of Calgary in 2009. There she is currently an assistant clinical professor and a full member of the MS research program with the Hotchkiss Brain Institute. For over 10 years, Dr. Burton's research has focused on the role of vitamin D in MS disease activity and neuroprotection, with ongoing studies and trials in this area. She has also developed escalation protocols for aggressive MS and neuromyelitis optica spectrum disorder, and is the co-director of the autologous hematopoietic stem cell transplant program for multiple sclerosis at the University of Calgary. She participates in the evidence-based medicine educational program for neurology residents and supervises students in a variety of research settings. Welcome, Dr. Burton.
Thank you. All right. Well, thank you so much to the MS Society for inviting me to give what is actually an update about multiple sclerosis in the era of COVID-19. We had a similar, but obviously different talk a couple of years ago when this first came up, but I'm hopeful we can provide a little bit of an update because so much has happened in the last couple of years. So these are my disclosures. And just a little bit to say kind of where we are right now with COVID in general. So as of at least the end of August of this year, there were over 604 million confirmed cases and likely millions more of unconfirmed cases in the world. Over 5.3 billion people have had their first dose of vaccine, and another roughly 5 billion people have had 2 doses or what would be a full series of the vaccine. And there have been over 12.5 billion doses of vaccine given out worldwide. In Canada, 31.5 million people are considered fully vaccinated, which is 83% of the population, or 88 million doses. So we're doing reasonably well. Just a quick reminder about the virus itself. So, this is a coronavirus, and it has similarities to the SARS virus that came out in 2003. It is currently the second most contagious virus in the world. Measles is the first. Initially, fatality rates with the original form of the virus were 2 to 4%. With the current Omicron strain, the fatality rate is much, much lower. But as we all know, transmission is typically done through asymptomatic carriers. Common viral symptoms include cough, fever, shortness of breath, but there are other forms, diarrhea, delirium, headache. And obviously, not only does this disease impact the respiratory system, but does have significant impacts on the nervous system with loss of taste and smell, delirium, myelopathies, clots, strokes, and other complications. So here's what we know about risk factors for having a poor outcome. We know advanced age, male gender, obesity, smoking, chronic medical conditions such as diabetes, kidney disease, and hypertension, immunosuppression, disability associated with immobility, pregnancy, and now we know being unvaccinated is another risk factor for a poor outcome if you acquire COVID. But let's talk about COVID in people with MS. So here are some what we've learned about particular demographic risk factors in our own world. We know that people who have a progressive form of MS are 2 to 4 times more likely to have a poor outcome from a COVID infection versus those with a relapsing course. Not surprisingly, those with moderate disability, which is an EDSS 6, which is needing a cane or higher, is associated with a worse outcome. Long disease duration is associated with a worse outcome, and that's often because a long disease duration is often linked to disability. We know that recent exposure to corticosteroids may impact a worse outcome, and we know being non-ambulatory is associated with a greater risk of ICU admission, ventilation, and death. And then we'll talk a little bit more about what we've learned above and beyond that. This is a publication that came out early in the pandemic with regards to people with MS and COVID-19. And obviously, these outcomes were predate vaccination. And what we learned was, by and large, people with relapsing and relatively mild disease were much less likely to require hospitalization and much less likely to succumb to COVID. And just like in the general population, we found that increased age, male gender, obesity, cardiac disease, and high disability rate were associated with worse outcomes. We also learned, at least initially, that the people in terms of treatment for MS, the people at greatest risk were actually those not on any treatment, and that may be related to the fact that people not on treatment are likely greater in age and perhaps have greater disability than people on treatment. And overall, at least initially, it wasn't clear that any particular treatment was a risk, although we've learned since then there may be some more to it than that. This is the COVIMS registry, which is North America and Mexico. This was an early publication as well in 2020 with a large number of patients. And again, what was found is greater age was associated with greater risk. And in the United States and North America, having an ethnicity of being Hispanic or Black was also associated with a greater risk of a poor outcome. They found that for every 10 years increase in age, there was a 30% increase in the risk of hospitalization in ICU and a 76.5% increased risk of death. As has seen before, males had a greater risk of hospitalization versus females. So non-Caucasians had greater risks. People who had worse ambulatory scores were at significant risk. And again, those with cardiac risk factors and hypertension were at greater risk. This group found that the use of the disease-modifying therapy rituximab was associated with a greater risk of hospitalization, as well as the use of ocrelizumab, although not necessarily the severity of the infection or death. They also found steroid use in recent months was associated with greater risk of hospitalization or death. But with the other disease-modifying therapies, there didn't appear to be any trends. This is the International COVID Registry, which contains a lot of countries' specific registries built into it. And so this is a large number of patients, over 5,000 at this point in time. And this is a little bit of a small graph, but basically what this is showing is that with regards to hospitalization and MS medication use, what you can see is this line is the zero line, and this actually is populated by people on Copaxone or Glatex as sort of the meter stick by which all other risks are measured. And if you're above the line, you have a greater risk of hospitalization than the zero line, which is Glatex. And so we see that people on no treatment have a greater risk of hospitalization, and this has been shown before. But when we move into the different treatments, we see that above this zero line, we're seeing a signal for people on B-cell therapies, which includes rituximab, ocrelizumab, and ofatumumab, which brand name is Kesimpta. And so that kind of highlights those groups. What's interesting, though, is, again, the risk factors that we've seen before keep showing up. So age, male gender, progressive MS, high disability. And this is ICU or ventilatory support. And again, we see this circle here represents people on B-cell therapies like ocrelizumab and rituximab. This circle here represents people on no treatment. And I've included a little circle here around people on S1P agents, which includes fingolimod or Gilenya, or siponimod or Mayzent. And as you can see, those people don't appear to be at increased risk. And there's been some concern about that group of people because of the mechanism of that drug. But regardless, in this group of almost 6,000 people, people on the S1P agents don't appear to have an increased risk of hospitalization or requiring an ICU or a ventilator. And then when we move on to, let's get rid of those people here. And now we're talking about death. And thankfully, these numbers are small, which is why the bars are relatively smaller compared to hospitalization and ICU. But unsurprisingly, that same group of people in red using B-cell therapies or on no therapy at all appear to have a relatively higher risk of death, not incredibly high, but relatively higher. And reassuringly, our S1P agent users, such as fingolimod or siponimod, they do not appear to have an increased risk of death. And so that's going to come up a little later in our talk as an important and reassuring sign. So let's keep moving. This is data from the Italian group, and it's a little bit small, but basically they show the same findings as everybody else: greater age, male gender, greater disability, and the use of B-cell therapies are associated with a greater risk of a poor outcome. And so I think put together, I'm just going to go back, put together, that is pretty reliable. And so this is a bar graph from the same Italian group, a little bit of updated. And they're looking at people in the lower risk group. So these are younger people with less disability versus people with a greater age and greater disability. And what they find was expected risk of COVID infections is in the dark bars, and what was actually observed is in the lighter gray bars. And so what they found was if you're on just any DMT, it doesn't appear to really matter in terms of observed versus expected outcomes with COVID infection. When you're on no therapy, no surprises. But they did see, even in this younger, lower risk group, B cell therapies, the COVID infections appeared to be more common. When you look at people who are a bit more disabled, um, all use DMTs and no therapy had greater numbers, which we know is a risk factor. And again, not surprisingly, so is B cell therapy. There had been some suggestion initially that if you're on an old school interferon, you're actually protected. It doesn't appear to be the case. It just seems that you're at no greater risk than someone in the general population. With regards to fingolimod and S1P agents, there was one group that did appear to find that there was a greater risk of infection in people who use these medications versus people on other DMTs. They found, not surprisingly, as everybody else has found, that B cell therapy users do appear to have a greater risk of infection. But they also found that this risk was present in the fingolimod or S1P users, but they pretty much stand alone amongst a multitude of other groups who did not see that. Okay. And so I think the take-home message before we move on is, for the most part, people with MS share the same risk factor profiles as people in the general population with regards to catching COVID and having a worse outcome. But in our MS cohort, in addition to those risk factors, people who are using B cell targeting therapies may be at a somewhat greater risk, although the magnitude of that risk does not appear to be extreme. So let's talk about the vaccines. So, in contrast to my last talk, I now have the ability to talk a great deal about the vaccines and some data about them, which is a nice change. And so I'll start with the mRNA vaccines because that is predominantly the vaccines that are used, at least in North America, presently. And so these are mRNA vaccines, and we have two approved therapies within the mRNA family. One is the Pfizer vaccine, the other is the Moderna vaccine. And just to remind you, the mRNA vaccines work by having a small piece of RNA that codes for the spike protein on this virus, which is a spike that is on the outside of the virus. This component of the virus has no potential to cause harm, but it is specific to this virus. And the RNA, what it does is it stimulates the cell's machinery to make more of these spike proteins. And as soon as the RNA has given the cell that set of instructions, it degrades. And so basically, these spike proteins are produced, and the immune system is alerted to recognize these spike proteins. And the next time it sees these spike proteins, it's going to attack. And so it creates a cascade that creates memory cells and antibodies that target the spike protein on the COVID virus. This vaccine has no interaction with the cell's DNA. And so, in spite of a lot of issues that have been raised and concerns that have been raised, this virus does not alter your DNA in any way, shape, or form. And the RNA, once it's done its job, degrades and disappears. So the current approved, some trial data about the current approved vaccines, we have our Pfizer vaccine. This was a large trial with tens of thousands of people. The regimen was 2 doses, 21 days apart. Incredibly striking, at least during the Alpha and Delta variant life of COVID. Very few people acquired COVID in the treatment group, and no one who acquired COVID in the treatment group required any hospitalization. Obviously, things have changed a little bit since the virus has changed as well. The Moderna virus, again, an enormous trial of tens of thousands of people. This vaccine is given 28 days apart for the first 2 doses, and very similar results. Almost no one in the treatment group acquired COVID, and no one required medical attention or hospitalization. Obviously, the situation has changed. The Omicron strains of the virus evade these vaccines in terms of just simply acquiring an infection. And so even if you're fully vaccinated with these vaccines, you still can easily acquire the Omicron strain. That being said, you are very unlikely to have significant illness if you acquire the Omicron strain and you are fully vaccinated. So you may have a mild URTI, but by and large, unless you have significant immune deficiencies, being fully vaccinated likely means you're in for a cold-like illness, but that you're very unlikely to need medical attention, hospitalization, or greater care than that. And that's been shown again that people in the ICU who have Omicron infections are not the fully vaccinated patients unless they are immune compromised and likely couldn't mount an appropriate response to vaccine. And this is just a little word about the AstraZeneca and Johnson vaccines, which were DNA viral vector vaccines. I'm not going to really talk about them because they're not given anymore in North America. They were efficacious, but they were associated with increased risk of clotting. And although those numbers were small, those are not vaccines we're using anymore in North America. And then the other vaccine that's approved in Canada is a protein-based vaccine called Novavax. It's not readily available, but it is approved in Canada. And that basically takes a little proteinaceous piece of the spike protein combined with another little what we call an adjuvant, which allows the appropriate immune response to be made. And that's what's injected in a Novavax vaccine. And it also allows the immune system to recognize the spike protein and mount an immune response to it. And this is the data from the Novavax trials. So again, this is not an mRNA vaccine, but it is using the proteinaceous part of the spike protein. Again, there's no DNA involved in this process. And this was a trial of roughly 15,000 people. And this vaccine given twice also showed very few patients acquiring the vaccine. We also know that the Novavax appears to be more resilient with regards to the Omicron strain. And so, unlike the mRNA vaccines, Novavax appears to provide better immunity to the Omicron strain. And immunity on Novavax may last longer than mRNA vaccines, but it's not the one that's readily available. So let's talk about MS and vaccines in general, because there's a long and storied history about the concern about vaccination in MS patients. For the most part, a lot of vaccine recommendations in the past weren't evidence-based. They were theoretical concerns. And I think the most important point to make is MS is not a disease of immunosuppression. MS patients aren't immunosuppressed. In fact, the issue with MS is an immune system that is too active in an inappropriate way. It's the medications we use for MS that may lead to immune suppression. And for the most part, a lot of the MS medications don't really lead to frank immunosuppression. There is no solid evidence that vaccines cause MS activity or the breakthrough of true lesional MS relapses. What vaccines may do is they may cause a febrile response and the transient worsening of symptoms, just like any other vaccine might, and just like certain infections might. The bigger issue about vaccines in MS is how MS treatments might impact our response to vaccination. Live vaccines are also an issue if you're on certain MS medications. And so people will often be told to hold their MS medications while they're receiving necessary live vaccines. The COVID vaccines are not live vaccines. And the truth is, there's probably data to support that even we're a little too worried about the risk of live vaccines in MS therapies. But if it's safe to hold MS therapies while you're receiving a live vaccine, then that's probably the current advice. So let's talk about vaccine response in MS patients. So humoral response is our B cell response. We have two predominant arms of our immune response. We have humoral B cell responses and cell-based T cell responses, and they're both important, and they're both affected differently by certain medications. And the humoral response is your B cell response, and this is the target of therapies like ocrelizumab, ofatumumab, and rituximab. And so, not surprisingly, if you're actively receiving these treatments and you receive a vaccination that requires antibody production, you're not going to show a very striking antibody production response. Interestingly, if you're on fingolimod, and you will also show a weak B cell or antibody production response. And that's because a lot of the machinery that's required to make antibodies is hidden away when you're on a drug like fingolimod. And so this raises a lot of concerns, because if you want to actually make antibodies from a vaccine, you need the machinery to do that, and several of our therapies directly impact that machinery. And so it's a very valid concern. Now, the T cell arm of things is also very important in the response to vaccination and the ultimate production of an immune response to target infections the next time they're encountered. And reassuringly, if we go to our B cell therapy little graph here in purple, we see that no, there's a very good T cell response to vaccination. And so that's reassuring that that arm of defense remains relatively untouched, if not a little bit more potent, if you're on a B cell therapy once you've been vaccinated with a COVID vaccine. Fingolimod, however, impacts the T cell arm of the response as well. And so, in theory, this is very alarming, because fingolimod appears to impact both arms of our ability to make a good response to vaccination. And so you'd wonder, do people on fingolimod respond to the vaccine, or are they at really extreme risk? The other thing we've learned is our B cell therapies are not permanent, and over time, the impact on B cells wanes from your last dose of a B cell therapy, and around 6 months to a year, in most people, you'll start to see that group of cells repopulate, and as expected, the production of antibodies to vaccine looks better and is more robust the further out you are from one of these doses. And so let's talk about now some of the data we've learned in the age of vaccination. We know what things look like in MS patients on medications prior to vaccination, but what does it look like in the era after vaccines became available? And so this is a French registry. It included a handful of people with NMO, but it was predominantly populated with MS patients. And it included a period of time where vaccines were available. However, this preceded the Omicron strain that we're dealing with now. And not surprisingly, they found that there was breakthrough in vaccination, but it was predominantly in people on the B cell therapies and a handful of fingolimod users. But reassuringly, almost all of these patients had very mild infection. So in spite of breakthrough activity and in spite of it occurring in the group of people we suspect are at risk, for the most part, they did well. And this was, again, even prior to the milder form of Omicron. This is the COVIMS registry. If you remember, that's the North America and Mexico registry. At this time now, we have over 5,000 people in this registry. And this is just a little snippet from the registry. This is the deceased versus alive groups. It's a little bit small, but basically the good news is the deceased group is very small. There's only 104 cases out of over 5,000. And when you kind of scroll down, you realize, even though it's a small number relatively, the largest number of those patients are B cell therapy users, and by far and away, that's ocrelizumab. And there's really no signal in the fingolimod users. And so in spite of seeing all that immune data that says that cohort of people appears not to mount a really great response to vaccination, we're not seeing them in trouble in the real world. Just to kind of, and I thought this question would come up, I thought this was a good time to talk about, in terms of vaccination, what's the current recommendation for vaccination now that we have vaccines on and boosters on board? And I borrowed this slide from the Ministry of Health from the Government Ontario, but it mirrors the data across pretty much most provinces, including Alberta, where I'm from. And so currently in adults, which is kind of what I'll focus on, although it's not vastly different in adolescents, we still are, we initially were at 4 weeks between the first and second dose of vaccinations. Three weeks for Pfizer, 4 weeks for Moderna. But when the supply was a bit low, we stretched out that second dose up to 8 weeks. And the truth was that actually provided perhaps a better immune response. And so 4 to 8 weeks between the first and second doses is fine. In terms of a booster dose, if you're an otherwise healthy individual and you're not immunocompromised, the feeling is you're going to get a better response to that third and fourth booster dose if you wait a little while. And that's because you don't want to neutralize the booster. And so the current recommendation is 5 months for otherwise healthy adults who have no immune compromise. If you have immune compromise, you may not have mounted quite as potent a response to vaccination from the first 2 or 3. And so the boosters are suggested to happen every 3 months. And that's the current recommendation as well with the new bivalent Moderna booster, that it does include certain strains of the Omicron variant. And so this is for, as I said, the immune compromised. You want to wait at least 3 months, but probably not any longer than that, again, because your response to the first 2 vaccines might not have been as robust, and you might wane a little bit early. And so 3 months is ideal for immune compromised people. That doesn't include people with MS. It includes people with MS who are on medication that we know blunts the immune response. And even though from the recommendation standpoint that doesn't include fingolimod, I'm telling my fingolimod users that 3 months is probably reasonable based on the immune data I've shown you. So we've shown that vaccines are very efficacious in patients with MS, and that we may run into a little bit of trouble with B-cell therapy users, but if perhaps they wait a little while from their last dose, or they get boosted at 3 months, that may help reduce the risk in that group of people. And even though we see a bit more breakthrough in B-cell users, tends to look like they're doing mildly if they're vaccinated fully. And even though immunologically it looks like our fingolimod patients are in trouble, we're not seeing those numbers when I showed you all the data in fingolimod users pre and post vaccination eras. The other concern a lot of people have is, well, are vaccines going to injure me in terms of my MS activity? Is being vaccinated a risk because of my MS? Am I going to suffer more greatly because I have MS? So let's talk a little bit, first of all, about what's the risk to MS patients from just having COVID infection, because this isn't a vacuum. You're not getting vaccinated for no reason. You're getting vaccinated to avoid a serious COVID infection. So let's put it in perspective. So this is the Austrian group and their data, and they looked at over 200 people with MS, and they followed them pre-vaccination and post-vaccination to determine if MS activity, I'm sorry, not pre and post-vaccination, pre and post-infection. So they wanted to see if COVID infection was a risk factor for relapses, and actually not so much. If you look at people with COVID versus controls, the relapse rate didn't appear to go up significantly, and disability didn't appear to go up significantly. So that's reassuring. And this is the Israeli group, and this group, and this is the Pfizer vaccine, which is fairly exclusively used in Israel. They were looking at relapses in the context of vaccination. And I think that's where people are worried is, we've talked a little bit before about are vaccines problematic in MS, and it appears they're not. But people obviously don't want to do anything that's going to create new MS activity, and that's understandable. And so the Israeli group looked at people pre and post vaccination. And what they did was they looked at relapse rates after receiving first and second doses of the vaccine and compared that to relapse rates in the same time period in 2017, 18, 19, and 20. And what they found was, first of all, there was no uptick in relapses whether you had your first or second vaccine dose. And the rate of relapse activity in this cohort didn't differ in the era of vaccination versus these time periods prior to vaccination. The only caveat is that the follow-up period after that second vaccination dose was only up to about 2 to 4 weeks. And so they can't really comment on weeks and weeks later, but certainly, within the period where that vaccine is causing the most activity, there didn't appear to be an uptick in relapse activity. The Italian group, also representing 25 Italian centers and over 300 patients with MS, also looked at their Pfizer-exposed patients. And they looked at the incidence of relapses 2 months prior to vaccination versus the period of 2 months after vaccination. And what they found was there was no increase in relapse activity when you compared pre-vaccination time to post-vaccination time. And in fact, it didn't appear that any group factor like age or gender or even your disability status had any impact on your risk of relapse if you were exposed to the vaccine. This is a group from Kuwait, and they had quite a large sample of patients who received vaccination. This was done by questionnaire, and a large number of their 820 patient group responded, and of them, 300 were vaccinated. And what they found was, regardless of, it seemed like people had a little bit more acute classic vaccine side effects in the Pfizer group, fever, chills, arm pain, whether they got the AstraZeneca vaccine, which is in orange, or the Pfizer vaccine, which is in blue. But what did not seem to be significant and did not seem to differ between vaccine types was relapse activity. And then one final group, just because we want to make sure we're looking at everybody. This is a group from Czechia, which is the new name of the former Republic of Czechoslovakia. And this group followed prospectively over 1,600 patients who'd been vaccinated and followed them over certain time periods. So these represent the time periods before vaccine. And this final bar is the time after vaccine. And what this group showed was that after vaccine, they noted a small uptick in relapse rate in their patient cohort. So a 1.38 times higher relapse activity in the time period after vaccination to these time periods prior to vaccination. So a small uptick, but a significant uptick. This is, in comparison, what they saw based on COVID infection. And what they saw with regards to COVID infection was a more significant uptick in relapse activity. And so, as I said, you can't look at vaccination in a vacuum. You're being vaccinated to avoid a COVID infection. And so you really have to contrast this to what would be happening if you caught COVID. And what they showed was, although in their group, unlike all the other groups, there was a small uptick in relapse activity post-vaccination, this risk of uptick in relapse activity was more evident simply by having COVID. And so the take-home message is, by and large, most groups do not see an increase in relapse activity post-vaccination. But even in the rare groups that did, this was a smaller risk when you looked at it in comparison to what would happen if you actually caught COVID. So I'm going to talk now about the pragmatic issues of, well, what do you do if you're on one of these therapies? How do you and your doctor kind of decide, well, should I change anything? Should I hold anything? These are the guidelines that the Canadian Network of MS Clinics put out almost 2 years ago, and they really haven't changed. So for the most part, the conventional injectable therapies and drugs like teriflunomide and dimethyl fumarate, which are Aubagio and Tecfidera, do not impact your vaccine response, so you don't have to stop them or change your dosing schedule when you're getting vaccinated. With regards to fingolimod, it doesn't appear to matter. We know that your immune response is altered when we go back to those slides, but we're not seeing people on fingolimod having bad outcomes. And we know that holding drugs like fingolimod expose people to the risk of rebound relapses, which is a very significant side effect when it happens. And so we don't advise people to hold or alter their dosing schedule of this class of drugs. We also know people who use natalizumab or Tysabri don't have impaired responses to this vaccine. So we don't recommend changing the schedule of this drug. When we talk about the drugs that actually are the what we call cell-depleting drugs, where you take them for a prescribed amount of time, but not forever, and that they cause a blunting of certain pathways, but not forever, but clearly for a long time. Those drugs include cladribine and alemtuzumab, and they are shown to have a blunted response to vaccination overall if you dose fairly closely in time to your last dose. And so if you are able to wait 6+ months out from your last dose, that's recommended. In the middle of a very high presence of COVID in your community with high risk, you may have to do it sooner. And in fact, there's small data from cladribine that says even people who waited just a few months after being done with cladribine still seem to mount an okay immune response. And so with this class of drugs, if you have the ability to wait 6 months out from your last dose, that's recommended. And then we get into our B-cell therapies, which we've spent a lot of time talking about. It's very, when this issue came up, we had the Delta strain circulating. It was very, dangerous to certain groups of people. If you were unvaccinated, you ran the risk of significant complications. We had ICUs full of people. And so in spite of ideally wanting people to wait as far out from their last dose as they could possibly wait, as we know, that gives you a better response to vaccine when we're looking at antibodies. It really depends on what's going on in your particular part of the world. And so the feeling was when these recommendations came out, COVID was so dangerous and it was so prevalent that we kind of wanted people to make the best decisions they could and perhaps not waiting too long if being out in the community was extremely high risk. But if you are able to wait, as close to about 6 months as you can from your last dose without incurring any significant risks by waiting, that's probably best. You do want to wait about a month after you've gotten a vaccine before you resume these medications. And that's because these medications could interfere with those early changes in your immune system that are necessary to create that antibody response. And obviously, as things change, these recommendations may change. A couple comments on outpatient COVID therapies. So I'm not going to talk really about inpatient COVID therapies because I don't really, in my experience, treat people who have active COVID in the hospital. Well, that's not true. I do, but not solely. They're not there solely for COVID. But these are sort of the outpatient COVID therapies that are currently available that we're dealing with. So the first therapy I'm going to talk about is Evishield, which is a preventative therapy. This is not to treat COVID. This is to avoid COVID. Evishield is 2 intramuscular doses. It's a combination of 2 antibodies targeting the SARS-CoV-2 virus, and it's available to patients who are felt to be at risk and who are felt to be unable to generate that full antibody response we've talked about. And so that includes people on B-cell therapies and probably people on fingolimod. It's currently approved to prevent infection, and the dosing is expected to provide 6 months of protection. It's felt to be safe, and unlike the next drug I'm going to talk about, it's not felt to be a complicated issue with regards to drug interactions. And depending on where you live, you may get this through public health or through your family doctor, but this is a preventative therapy. And then the other drug is a treatment, and that's Paxlovid, which has been around a bit longer. And Paxlovid is oral, and currently in Alberta at least, it's used to treat individuals with mild to moderate COVID symptoms who've got a confirmed COVID infection, who are at risk of a severe outcome, and that includes people who are older, people who are immunocompromised, and it really works best if you're within the first 5 days. Interestingly, when they look back at how people respond to Paxlovid, what they found is people over 65, people between 40 and 65 don't really appear to generally have an impact. The Paxlovid doesn't really appear to have a profound impact on them. It seems to work best in elderly cohorts and immune-compromised cohorts. You've probably seen in the news, people seem to have rebound positive test results. It's not really clear that that wouldn't have happened anyway without the Paxlovid, but Paxlovid is complicated, not necessarily because of who should be on it, but because it interacts with just about everything. So this is a very long list. And what you'll see is a little red circle. A red circle means do not combine. A green circle is watch out. A check mark is that's fine. And these are all the drugs that have the potential to have an unwanted interaction with Paxlovid. And this includes a huge number of drugs that people might be on: anticonvulsants, anticoagulants, antibiotics. And so and lipid-lowering drugs. And so Paxlovid really should be used with full information about what the patient is taking. And can you stop some of these drugs? Is it safe to stop some of these drugs to take Paxlovid? And so I don't purport to be an expert in this field, and thankfully that's not something I do in my current practice. But Paxlovid is a bit complicated. So I leave those decisions to the people who are best equipped to make those decisions. But Evishield seems to be a bit of a simpler option. And so it may be wise to consider talking to your care provider about Evishield if you are in one of those risk categories and you may be exposed to COVID infection. So some of the take-home points I want to focus on. So the SARS-CoV mRNA vaccines, and Novavax as well, for that matter, have an excellent safety profile, both in the general public and in MS patients, and literally have been used by billions of people, and you're not going to see any uptake with that kind of numbers. COVID infection poses a much greater risk to both the general population and MS patients when compared to COVID vaccines. So again, yes, COVID vaccines may have some risk factors, but in contrast to COVID infection, for the most part, those pale in comparison. Patients on B-cell therapies have a small but identifiably greater risk of a poor outcome with COVID-19. And depending on the current level of infection in your community and individual disease activity, it's something to discuss with your MS provider if there should be any changes made to optimize your vaccine response. There's evidence that boosters and idealized spacing of dosing in B-cell therapy users may actually improve your antibody production, but it's important to note that T-cell responses, which are still a very important part of vaccine response, are as good, if not better, in people on B-cell therapies. And that may be why, although there's a small risk to this group, it's not an extreme, overwhelming number of these patients that we're seeing do a little bit worse with COVID. And interestingly, in spite of, at least at the level of the immune system, not seeing a great deal of response to vaccination in people on S1P agents like fingolimide, we're not seeing these people in our hospitals or our ICUs. So clearly there is more going on at the immunological level than we understand in terms of how these vaccines are protecting patients. And there's evidence that preventative treatment and possibly active treatment for COVID infection is beneficial to those at risks, including Paxlovid in those patients over 60. And then finally, the pandemic is not over. Our hospitals, our numbers are going up. People are coming in with COVID infection, or their illness is being made worse because of a simultaneous COVID infection. The healthcare system is still under profound strain with the issues that COVID has unleashed, not simply direct illness, but how that impacts staffing and infrastructure. And so, I think that's important to remember, that when you protect yourself from COVID, you're also helping protect the community at large, not just from COVID, but also protecting them so that the healthcare system can continue to be there and look after them for any and all problems. And so I'd like to thank the MS Society for inviting me to talk. I'd like to thank my colleagues in the clinic group and my colleagues across the country who've helped acquire this information, do these important studies, and also my patients who've been really helpful and patient with us while we're trying to figure out the best way to look after them and dealing with all this uncertainty, not just, again, for their own safety, but the safety of everybody in the population. So with that, I'm going to close my talk, and I think now we're going to open it up to questions, but I will make one caveat. I'm not an immunologist, and I'm not an infectious disease specialist, so there may be things I'm just not fully equipped to answer. So apologies in advance if I just can't answer certain questions.
Okay, Dr. Burton, thank you very much for that informative presentation. Picked up a lot of information there swirling around in my head. I do have one question, not for you, but for our tech guy. I'm not sure if I have time to go into questions. Maybe they can send me a message or let me know if we can go straight into questions or not. But I will ask this one question. COVID is not going anywhere, or it's not going anywhere fast. So should people who are not on a DMT seriously reconsider starting on one, if only to reduce the risk of severe outcome due to a COVID infection?
Well, I think we know that MS patients who are not on DMTs appear to be at greater risk, but that's with the likely fact that that group is made up of people who are of advanced age, who wouldn't normally be on a DMT, or people whose MS may be progressive, who for the most part wouldn't normally be on a DMT. And if you probably remove those people from that group and just leave behind younger, otherwise healthy people who are not on a DMT, they're probably not contributing to that risk. And so I think using a DMT solely to protect you from COVID isn't necessary. We have excellent vaccines that do a good job of protecting you from COVID. So I think your DMT decisions should still be based on your MS and the guidance from your MS provider. And obviously, thankfully, we have a lot of choices with DMTs. And so I think obviously your concerns about everything, including COVID and all the related issues that come up with DMTs, would go into your decision. But I think your provider is there to give you the information that's best tailored to you, risks, benefits. So I am still using B-cell therapies in significant numbers. I want my patients ideally to get as vaccinated for COVID and anything else they need prior to starting it, so they have the best protection against illness that they can possibly have. But again, you have to balance that out with protecting people from MS itself, which, in some people is a greater risk. So these are interesting questions, but a DMT is still, I think, by far and away best suited to your MS, and protecting yourself from COVID by far and away is best served by getting the recommended vaccines.
Okay.
And
Can you get a
masking.
COVID-19? Sorry?
And always mask. I still recommend masking in indoor activities and in situations where you don't know your risk profile and you're not with your bubble. So just a shout out to public health initiatives to protect people. They're still very helpful. And so you can still protect yourself a little bit better, even though a lot of places have dropped mask mandates and things like that. Make the best choices for yourself that you can.
19 booster and seasonal flu shot at the same time, or what spacing recommendations would you should people have?
At least in other countries, they are giving flu shots and the bivalent booster concurrently. There should not necessarily be any problem with that. I am not, as that has not yet been put out by public health. Flu shots are not yet out and available in Canada, so I don't know what will be actually recommended by NACI, which is our advisory group, and individual provincial groups. So the recommendations may be different, but as far as I'm aware, there shouldn't be any significant risk of receiving these vaccines together. That's with the caveat that I'm not an immune expert, but I do know that is currently underway to our neighbors to the south.
Okay, thank you. Well, we've come to the end of our time for questions. Actually, we're over our time, but thank you again, Dr. Burton, for your time and sharing your expertise on today's presentation. To our viewers and our listeners, Dr. Burton mentioned a treatment called EvuShield, and the MS Society is lobbying to have access for people living with MS age 12 and older who have been fully vaccinated with 4 doses of an mRNA vaccine and who use the disease-modifying therapies to have access to receive EvuShield prophylactically. That's to maximize protection against severe outcomes from SARS-CoV-2 infection, otherwise known as COVID-19. And if you'd like more information about EvuShield, please contact the MS Navigators. Now, if you'd like to support the efforts of the MS Society, you can do so by sending an email to your provincial politician to increase access to this treatment. An MS Navigator can also help you with that as well. Then talk to your healthcare team to explore what treatment options are best for you. Before we wrap up, we want to remind you about the MS Knowledge Network, which is staffed by trained navigators who provide consistent, quality information and support. You can connect by phone, email, or live chat through the MS Society's website and know that the interactions and information is trustworthy. If you'd like to sign up for the monthly e-newsletter, an MS Navigator can help you do that as well. So when you receive the e-news, you are kept up to date on the latest MS research and treatments, the programs and services offered by the Society, fundraising and volunteer opportunities, inspirational personal stories from people affected by MS, and so much more. And it's all delivered to your email inbox each month. And you can be part of the MS community. We encourage you to get involved with the programs, services, events, and volunteer opportunities. These days, connecting with each other is so much more important than ever, and more information is available on our website at www.mssociety.ca. Also, we encourage you to visit wechallengems.ca to learn about how you can help to raise funds which are needed to maintain our research commitments, advocacy initiatives, and programming to support those affected by MS. Very soon, you're going to receive a survey by email about today's webinar, and we encourage you to fill it out. For the Facebook Live audience, the link to the survey is already available at the top of the chat. We ask that all viewers complete the survey. The information collected from the evaluation will let us know if today's discussion was valuable to you and what topics you would like to see covered in the future. It'll only take a couple of minutes, and your feedback will go a long way to help us when planning for future educational sessions. On behalf of the MS Society of Canada, thank you for tuning in for today's broadcast. Goodbye.